Hi, and welcome to this month's Class K2 Web Forum. We're so excited for today's guest and topic today. But before we get started, I want to introduce myself. My name is Boyd Stewart. I'm here with my colleague, Aureen Wilford, and together we lead up Class's K2 initiative. And really it's designed to, or mission is to help reduce the friction between payers and providers and really reduce the inefficiencies and improve the efficiency between those two entities. Through that, we have these web forums, which we will get to shortly, but we also are in the middle of validating and doing interviews for our Points of Light, which we're really excited about, and that'll publish early next year. So watch for that. As well as in May, on May 13th through the 15th, we're going to be convening for the annual Class K2 Summit. It's going to be here in Salt Lake City, and if you need more information on that, please reach out to pol@classresearch.com. And with that, we're excited for today's Class K2 Payer Provider Web Forum. We're so excited for our guest today. It's Dr. Bruce Rogan from the Cleveland Clinic. Right now, he's a Chief Medical Officer for the Employee Health Plan for the Cleveland Clinic, as well as the Chair of the Cleveland Clinic Quality Alliance since 2017. Most importantly, I consider Dr. Rogan a friend. We seem to crash each other's parties at several events every year. So we have a lot of common friends and interests in healthcare, and his passion for improving healthcare for patients and patient members is intoxicating, and we're so grateful for him to be here with us today. Dr. Rogan, how are you doing today?
I'm doing great, thank you, Boyd. Pleasure being here.
Good. Well, Bruce, we're going to start with a question here. As we look at we have a couple goals as we look at this today. We want to get to where we need improvement, but I want to start where things are going well and where we've seen improvements, specifically at the intersection between health plan and health system, for the benefit of patients or for just the benefit of cost and reduction of friction. What are you seeing recently that's really benefiting that area?
Good question. So over the last 5 to 10 years, what's been really nice to see as it happens real time in the interactions between payers and providers is increasing trust, increasing sharing of data, and an increasing acknowledgement on both sides that we need to work together, that we cannot be in conflict, and that in the end, both the providers of care, the physicians, the nurse practitioners, PAs, RNs, the whole health system, and the payers who are responsible for covering the cost of care need to work together to meet that quadruple aim, those quality, cost efficiency, utilization control, patient satisfaction, provider satisfaction aims that we're all striving for. So I would say, yeah. So what's really positive is our ability to work together and our ability to share data.
And it's interesting, the technology to do that has existed for a long time, and it feels like just recently we've seen a kind of an increase in the willingness to pull those levers and turn those dials. What happened on the technology side to help alleviate some of the distrust? And I'm not saying that there's not distrust today, but it certainly feels like in some areas it has alleviated some. What's driven that?
Yeah, it's a good point. The technology has been around for a while. I think it was the mistrust and the health system side not wanting to necessarily share clinical data, certainly not a lot of clinical data, with payers. They also felt, I believe, that claims was sufficient. So in the past I had heard, the comment that as long as the payers had the claims, what else did they need? Of course, that's not the case. Both payers and providers working together need clinical and claims data combined in order to meet our metrics, in order to advance quality, in order to have each side of that equation show to the other that we are meeting our shared goals and have our shared incentives being provided. So it's been interesting. I think that combination of claims and clinical data has been going on for a while now, but it's much more advanced than it used to be. the fact that we now can create longitudinal patient records pulling from multiple claim sources and multiple EMRs, multiple clinical sources, is hugely helpful. In the past, it was a big struggle to even figure out, is this patient attributed to us? Are they attributed to that payer? Where is the data from that patient coming from? And especially if the patient had a common name, it was almost impossible to figure out who's who and what's what. So we've made a lot of progress in the last few years.
Well, not only that, but you get that list right, and then we come to where we're at right now in the season of re-signing up for benefits, and a lot of those patients move, and it's just a constant fluid movement of those resources and those people.
Yeah, it's very difficult. Physicians know it's very difficult to take care of patients when you don't have a full clinical history, when the patient is new to the physician or new to the health system or limited data in the EMR. And the payers have the exact same problem. They're picking up a new patient that they've never been responsible for, and they don't always have the full history and the full information around what that patient's had in the past. What vaccinations have they had? What cancer screenings have they had? What prior conditions have been treated and will need to be treated going forward? So, pie in the sky, ideal state, the payer knows everything they need to know in order to cover care, and the provider knows everything that they need to know in order to provide care. And we're still a long way from that, but we're getting there slowly.
What's the next gap to close there, would you say?
I think part of it is around social determinants of health. Part of it is around subjective data collection. Ideally, you always want objective data, but sometimes we can't get, particularly around social determinants of health, to objective data. So where does patient-entered information come into that whole data system? Where do devices, remote patient monitoring, glucometers, blood pressure cuffs, how does that feed data into the data system? And how is that collated with all of the rest of the information that's available? So I think we're working on those gaps. Again, across the country, there's still not great interconnectivity. We think we're there, but we're really not. We're on Epic, and that helps because Epic has a lot of good connections with other Epic systems and with other EMRs, but it's still gaps. The ones I can think of immediately are I'll get calls from patients who have been admitted and discharged elsewhere on vacation or across the country, and I have no visibility into what happened because that system isn't connecting to ours yet.
No, that's so helpful.
Dr. Rogan, as we look at other areas of opportunity for improvement, we're hearing from health plans and the care providers that pharmacy is an area that there can be more progress. What are your thoughts on that?
Yeah, pharmacy is a huge pain point on both the payer side and, to an extent, the provider side. What I see, what all of us are seeing is that pharmacy costs are rising at a much higher inflationary rate than medical costs in general. It used to be that pharmaceutical costs represented 15 to 20% of the total medical spend for a plan. Now it's approaching 40 and probably soon to be 50%. And when I say 50%, I don't mean pharmacy is half the cost of medical. I mean pharmacy is half the cost of combined medical and pharmacy. So it's approaching almost the same cost for the medical care as for the pharmaceutical drug provision. That's a little insane, but we're getting there. We have a lot of multi-million-dollar drugs coming onto the market. Every year there's more and more very expensive drugs tailored to what are rare conditions, but they're rare in terms of, okay, a health plan of 100,000 may only have 2 or 3 patients with that condition, but if that's $10 million of annual spend because of those 3 patients, that's huge. And there are multiple rare conditions like that we're now seeing that sort of spend for. So informing providers of the best way to be cost efficient about prescribing pharmaceuticals is a constant battle because of direct-to-consumer advertising, where patients are coming in with their own requests for drugs that may or may not be the most cost-effective drug for them. Physicians are in a state of being burned out and having less time to spend with patients than they used to. And most physicians are not in a position when they see a patient in the office or on a telemedicine visit to spend half the available time discussing appropriate pharmaceutical choices with the member. Instead, what happens is the physician will often prescribe either what the member requests or what the physician may have just been informed of by a drug rep or a pharmaceutical manufacturer, and that may or may not be the most cost-effective, cost-efficient drug. And this is a serious problem. I could go on for hours. I could just throw out the simple phrase anti-obesity medication and tell you that if we can't figure that particular piece out, you're going to see healthcare costs in the United States go up by 30% over the next 24 to 48 months just from that.
That's interesting because you mentioned, the example you gave is 3 patients, needing a volume of $10 million in drugs, for example. When you're talking about obesity drugs or weight loss drugs,
it's the inverse.
It's the inverse, where maybe it's not millions of dollars per patient, but there's just millions and millions and millions of patients.
Yeah. When you look at over 1/3 of the United States population meets the FDA criteria for GLP-1 drugs for obesity, that's an enormous volume. Now, not to say they're all going to end up on the medications, particularly now because they're injectable, but give it a couple years when they become oral, and if the side effects are minimal, and they may not be minimal, but we're still finding out as a higher and higher volume of patients begin to take these drugs. But assuming that the side effects are minimal and assuming that this becomes an oral product, we are looking at the potential for as many people taking these anti-obesity drugs as take blood pressure pills or statin medications for cholesterol, with the slight difference that most blood pressure medications or statin cost pennies to less than $1 a day, and these drugs are costing more like $4 to $10 a day, and that is a huge difference.
So for an organization like Cleveland Clinic, as you guys consider, you have about 200,000 lives, if I remember right?
Actually 120,000, Boyd.
120,000. Still, a significant amount, but not as many as we see other plans cover, right? How do you weigh the pros and cons? How do you even start the conversation on covering a medication like that? This just as an example.
That's a great question. So we have internal content experts. We have our own endocrinologists and our own bariatric specialists. We sit down and talk with them. We point out to them what the costs would be at various levels of coverage. And actually, the enterprise has to make a determination about what they're willing to cover and what the cost share should be for the employees on these drugs. And there are some tough decisions being made. I don't know if you heard, but the Mayo Clinic, as an example, just set a lifetime dollar cap on the use of these medications. The cap that was set based on the announced price for the latest medication, Zepbound, means that they will basically get 2 years coverage and then they have no coverage left. So that would be not an issue if these drugs were curative, but they are not. You have to continue to take them. So there's some very difficult decisions that are going to have to be made. Or, ideally, the price will come down. But so far, we haven't seen much price reduction, at least not in the last several years.
Yeah, I have so many more questions, but they're coming from a place of ignorance. And this is a very sensitive and controversial topic.
Oh, yes. Oh, yes.
As far as what rights and access and those things specifically to these weight loss drugs. So, what about post-acute care and transitions of care?
Yeah.
These come up as challenges for many.
A lot of work being done on that. As you know, with Medicare's readmission rules, where readmissions don't get paid for the most part, we need to figure out 3 very important pieces in order to make this work. The first, for years now, inpatient utilization has been dropping as we do more and more procedures as outpatient. So that's hugely helpful, that we do a lot more in the outpatient setting now than we used to do in the inpatient setting, or that we used to do in the inpatient setting. That needs to continue. There are more things that we now admit patients to the hospital for that could be moved to the outpatient setting, ideally. The problem there, of course, is lost revenue for the hospitals, but that's the direction that it needs to go in from a value-based care point of view. The second piece, besides continuing to move inpatient to outpatient, is at the time someone is discharged from the hospital, everything needs to be in place so that they do not get readmitted and so that they go to the lowest level of care at the time of discharge. So we have patients right now that go from the acute setting to the post-acute setting and end up in maybe acute rehab or maybe long-term care, maybe skilled nursing facility, maybe home health. All of that needs to downshift if possible, meaning that some of the patients that now go to acute rehab, could they be handled at home with home health and more intensive home rehabilitation? Could patients that currently go to skilled nursing facilities be handled in the home with the right remote patient monitoring and the right providers coming out to the house to provide care? Essentially, there's a hospital at home movement where patients that may need to stay a couple of extra days in the hospital for safety and security and care reasons may be able to be sent home with the appropriate resources at home. And that's the next big piece, is how do we take the folks that had to be admitted to the hospital, get them out sooner, get them to a lower level of care, but with the same safety and security and efficacy and quality outcomes that we've come to expect from all of those expensive post-acute facilities.
One of the things that CLASS is starting to measure more and more of is remote patient monitoring technologies and solutions, and man, that's a broad topic, and I'm not the best person at CLASS to talk about it, but when you talk about patients in the home, do you see, when you talk about some of those gaps and transitions of care and post-acute care, do you see specific vendors or types of vendors or opportunities where you'd say, hey, it'd be really great if a vendor did this or had this solution? And I say that as if someone could just wave a wand and just plop, there it is.
Yeah.
But if you had that wand or had that wish, what gaps do we have, or do we not know what we don't know?
We know a little bit of what we need to know, but there is still a lot we don't know. One of the big gaps, again, as I think about remote patient monitoring and connectivity, is there's too many solutions for disparate parts of the problem, and no one single or even 2 single solutions that cover everything that would be needed. So one of the things that I see that we currently still lack, and I'm sure there's a couple of vendors that if they heard me say this would be, no, we do that, but they really don't, not that I see, is that one-stop shop that, here's a device, We stick it at home. It acts as a two-way synchronous audio-visual connection. It also has connectivity to pulse oximetry, glucometer, blood pressure, respiratory, even fall detection and movement detection. Wouldn't it be nice if you had someone at home and that one device, basically would alert the care team if the patient fell or was at risk for falls by the way they were walking or moving about, what their blood pressure and respiratory rate was, what their pulse oximetry and blood sugar was. Continuous glucose monitoring right now is one solution, but how interconnected is it with everything else? And then that audio-visual communication, the ability to say to the patient at any time if something goes wrong, we've just noticed your pulse oximetry is now below 90%. Are you feeling short of breath? What's happening? And the second piece is, again, the care team going out to the house. So remote connectivity is part of it, but another part of it is you probably need someone at certain intervals in the home to be able to evaluate the patient on a regular basis if you're actually going to be getting them out of the hospital and out of the acute or post-acute setting and back home safely. And what the frequency is going to depend on the acuity of the patient and the resources that are necessary. It doesn't have to be a doctor. It probably wouldn't be a doctor in most cases. We've experimented with using paramedics in a paramedic program to go to the house. We certainly have, obviously, nurses and therapists, physical, occupational, and speech therapists that go to the home. We obviously have wound care and RN nurses that go out to the house. And then we do have doctors that go out to the house. It's amusing to me, having trained in the 80s and having been in medicine for close to 35 years now, to see that, the doctor going to the house, which we used to laugh at as, that was Marcus Welby 1960s medicine. We may be heading back to that.
So, Dr. Rogan, on that about your patients, members, home health, etc., how do you go about trying to incentivize them, educate them, and just empower them to choose the right care and take more ownership of their care?
That is something that I'm very passionate about, and I know Boyd is aware of this. We spend a lot of time and resources and dollars incentivizing providers to do the right thing. And providers want to do the right thing, but they don't always have the technology or the team or the infrastructure to do it. So we incentivize health systems to provide that for the doctor to be able to do the right thing, order the right drug, order the right test, see the patient when they need to see the patient. What do we do for the patient in terms of incentives to get the patient to do what they need to do? What do we do around incentivizing the patient to pick up the drug, to take the drug correctly, to report side effects from the drug, to tell the doctor if they have stopped taking the drug, to watch their nutrition and their diet, to get a regular amount of daily exercise, to do the physical therapy that we've asked them to do. All of that doesn't get incentivized, at least not in any meaningful or significant way. We've tried to do that in our own health plan by using premium discounts and dollar incentives to get patients to work on identified chronic conditions that we have identified and inform them of. And we've been very successful at getting quality to improve and getting cost under control for those chronic conditions where we've actually tied dollar incentives to our members. Now, we do that. Traditional Medicare doesn't do that. Medicare Advantage hasn't really done that. Medicaid hasn't and can't do that because there's almost no levers to actually move patients' behavior in those other plans and in those other benefit designs. So I would say one of the big things that we have not figured out how to do is how to get our patients, or our members, depending on which side of the provider-payer fence you sit on, to do the things we need them to do. I can get the doctors to order the labs. How do I get the patients to do the labs? I can get the doctors to order the drugs. How do I get the patients to take the drugs as prescribed? How do we reduce financial barriers? It goes back to what we were talking about, pharmacy costs. It doesn't do much good for doctors to order these drugs if the patients can't afford to take them.
Right.
Are there, other areas in healthcare that you feel are opportunities where we can improve, where there's help needed that you haven't mentioned today?
I think that around social determinants of health, and it's a loaded question, but there are things that the healthcare system could be doing that it hasn't yet taken the step. Now, part of the reason why the American healthcare system hasn't yet taken the step is because there's a lot of discussion about whether it's the health system's responsibility to help with those social determinant gaps. We talk about gaps in care a lot and how to fill them in healthcare. The gaps in care that we're talking about are labs that needed to be done, or screenings that needed to be done, or procedures that needed to be done, or drugs that needed to be taken. We don't talk very much about transportation difficulties and patients not able to get into the health system, access difficulties, food insecurity, patients that have diabetes or obesity, and we're not providing them with the nutrition, education, or dietitian visit, or in some cases, appropriate, healthy fruits and vegetables and food that they should be eating, but they can't either afford it or have a source for it. So one of my pet peeves, and I'll spend 30 seconds on this, you have a serious health problem when it's less expensive and more convenient for a family to go to a fast food restaurant and get a high volume of calories at relatively low cost, but they can't go to a supermarket in their neighborhood and buy fresh fruits and vegetables, either because it's not available in the neighborhood or they can't afford it because that costs more than the fast food. Years ago when I was in LA, we talked about the South Central Los Angeles food desert. And food desert is a common term now. Back then it wasn't so common. And there was like 100 square miles with 1 million people who had access to, and I don't remember the exact numbers, but it was like they had access to 7 supermarkets with fresh fruits and vegetables and healthy food, and access to 950 fast food restaurants. I won't mention all the names, but it was all the ones you could think of. And when you drive down a street and you have a fast food burger joint every 3 blocks, but a supermarket or grocery store is every 30 blocks, if that, that's a problem.
That's hard. As we talk to a lot of health systems and health plans specifically, they've come to us several times and say, hey, class, we are ready to invest significantly into social determinants of health technology, infrastructure, putting in, policy and programs in place. And our concern, class, is that the health systems right now aren't ready to receive that. We're concerned that the social determinants of health programs they have in place are based on a person's passion, an individual's. They're the health system that has their little pet project.
Right.
And I don't know how fair or not that is. I think that probably is accurate at some health systems. But it is a challenge because, as you say, I mean, if we ever needed to kind of dance hand in hand, health plans and providers, it's around that social determinants piece and really
It is.
advocating for them.
It is. And, again, having the data is step one, and we're getting there. But when you have actionable data and no actionable plan, it's not that great. So it's like, oh, we know we have a problem. Look at how awful the data is. But then you have to be able to do something about it. And in the United States, the question has come up with, is it the health systems and the health payers that are supposed to be doing something about this? Or is it more of a socioeconomic differentiator? One of the common arguments that I hear multiple times over the last several years is that the American healthcare system isn't so expensive compared to some of the other, particularly European systems, if you add in what we spend on government social programs plus healthcare in our country compared to what those other countries do. In other words, if you combine those two costs, in the US, 70% of the combined total is devoted to healthcare provision and only 30% to the social issues. In other countries, it's the inverse. They're spending 70% on the social issues and 30% on healthcare. And yet, they have better outcomes. So there may be something to be said there. But we can't tell people who can't afford medications or who can't afford transportation or food that we still expect them to eat the way we want them to eat, to access the healthcare system the way we want them to access it, and to get the outcomes that we expect. The system is designed for the results that we're getting, unfortunately.
And as always, I think it always comes back to change management. And finding the levers and the dials that we can push and pull and encourage. And it's, unfortunately, there's a lot of investment to be made, and the outcomes, it's a long play. It's a long play.
It's tough. And there's a lot of education on the providers, education on the payers, but frankly, education on society and on patients. We can fix some of these problems if we focus on them. I do believe that after decades in healthcare. I don't think that any of these problems are insurmountable, but they require a will. They require some alignment of incentives that we've never had. And they require applying incentive money in areas that we have not considered applying it.
Well, we can't thank you enough, Dr. Rogan, for your time and your expertise and your passion here. We can feel the desire you have for these patient members and their lives and just the outcomes that we want to see. And in addition, as we responsibly handle the costs that these employers and these patients give us to control.
Yeah.
So thank you so much for your time. I assume I'll run into you at the next conference I'm at, and or somewhere else. Whether it's related to healthcare or not, I tend to expect it now.
Yeah, I understand. Yeah, we kind of run into each other about every 2 to 3 months, and that's a good thing. So I'm very pleased with class and the work that you do, and I'm happy to contribute whatever knowledge and expertise I'm able to contribute. So thank you for the invite for the webinar, and I appreciate the time to express my opinions and my thoughts.
Yep.
I hope I didn't wax too eloquent in terms of the lengthy answers, but thank you for being patient.
No, it was great, and we're excited to have your voice out in Salt Lake City for the summit in May. So we'll see you then. Thanks, Bruce.
Thank you.
Have a good one.
Thank you. You too.
Thanks, everyone, for joining us today, and we'll see you next time as we interview another healthcare executive on some of the ways that they see success happening between payers and providers, as well as some of the opportunities that still exist.